So let's take a journey through some of the ways we can help do our screening. So part of this presentation, I suppose we all have done anatomy and physiology, mostly of the male reproductive system. But basically here we are talking about the prostate and its adjacent or accessory organs. And we are going to look through the anatomy and the physiology, then the normal sonographic appearance. Now the prostate has two ways to be evaluated. One of them is transabdominal, which I think is the most commonest that we all have done. And then the new practice that is coming in of transrectal. This is supposed to be the truth. So the technique of the transrectal ultrasound of the prostate, and we'll briefly look at the common pathologies that we encounter. Now, at least we all know where the prostate is located. It is to the posterior and inferior to the bladder, urinary bladder. And its basic function, along with the accessories, is the prostate gland is basically to produce fluid. Now, this fluid, it protects and nourishes the sperms. We know where the sperms are manufactured, where they are stored, and how they come. And then the purpose of the prostate is basically to provide that protection and then to nourish it. Then in this image, we have these, we call them the seminal vesicles. This is our prostate here. This is a coronal image, and this is our prostate here in the sagittal. Now, these seminal vesicles, also their function is to provide a fluid. This fluid has what we may call sugars, fructose in them. And the purpose of these sugars is to provide energy for the movement or for the motility of the sperms. Now, this particular image, I have put it, most urologists, this is what they perform. We call it the digital rectal examination. Just using your finger, tapping through the rectum, you can feel the prostate. One time I made a mistake and wrongly measured the prostate volume. But the urologist told me, Vitus, this prostate doesn't appear to be enlarged. I have done a digital rectal examination, but it doesn't appear. Could you review your images? And indeed, when I reviewed my images, it was not enlarged. It was over extrapolated calibers. So, our discussion today is majorly going to talk about what many of us have not practiced. Transrectal ultrasound, because it has more sensitivity to detecting pathologies of the prostate than transabdominal. And it is quite easier and quite tolerable, just like the abdominal. We are going to see the limitations. So, because most of our discussion is going to center about the transrectal, permit me to quickly go through the anatomy. Now, when you do transabdominal, basically what you look at the capsule of the prostate and then the general parenchyma of the prostate. But when you do transrectal, the parenchyma you see on transabdominal can be split into different zones. So, for example, if we take this image here, looking at the different colors, we have blue, we have this brownish, we have this whitish, we have this central green. So that is how much the transrectal can give us. It gives us those zones of the prostate, which we cannot be able to see on transabdominal. Now, This was a discovery because transabdominal misses so many pathologies, like we are going to see. So the prostate at transrectal is split into the peripheral zone, which is actually the biggest, the central zone, the transitional zone, which is the smallest, and then the fibromuscular stroma. And in most cases, this one is, is anterior. Now, when we are doing transrectal ultrasound, most of the ultrasound machines that we have, we use the endocavity probes. Those are the probes. You either use them for endovaginal. So they are the same probes we use here. But the difference here is when we use that probe, the endocavity probe, most of the machines on the market, it's by plane. It offers you only views in 2 planes. But in truth, there is advanced planes. There's advanced probes with more than 2 planes. You get images in sagittal, you get images in coronal, you get images in axial. Particularly for this discussion, we are going to look at the sagittal and the coronal. Just like you see these images here. This is a sagittal image demonstrating our central zone, the peripheral zone, the anterior fibromuscular zone, and the transitional zone. Then in the middle there is our urethra. And this is how it appears on the coronal section. In the coronal, you'll be able to see most anterior, the anterior fibromuscular, the transitional zone. Now, when you split up this prostate to these different zones, research has shown most of the cancers, 75%, will come from the peripheral zone. And then the central zone, which is the smallest, and which is the second biggest, contributes 20%. And then the transitional zone contributes only 5% of the cancers of the prostate. But again, this transitional zone is the site for benign prostatic hypertrophy. Again, the prostate can be further divided, or you can have a different other approach. If you have not used the zones, we use the divisions or lobes. We have the base. We know the prostate has the base and the apex. The base is towards the urinary bladder, and the apex is towards the valvulus of the urethra. And then if you did a good sagittal, mid-sagittal, you can either shift to the right or shift to the left. Or you can be midline. That is why you're saying the left, right, or median lobes. Now, I start with these images here, this particular image here. First and foremost, let me explain the image orientation. Or before I even explain the image orientation, the technique for doing the transrectal. If you are right-handed, of course, you must first seek consent, especially for the ladies. If you're going to work on a man, you're going to ask them to remove their trousers, their boxers. You need to seek consent. And your patient lies on the left lateral of the Vitus, with their hips and knees flexed. And then, of course, your probe has to be dressed in a protective material, whichever you opt to use in your department. And then you first have to lubricate the anal canal. And then please remember to warn your patient, I'm inserting in this probe, it's not painful. Sometimes you get some resistance because the anal canal is not something people are used to tampering with. Now, image orientation. My top part of the screen here is the anterior part. And then this side here is the posterior. This is why you see my image appears inverted. In actual sense, it's not inverted. Our approach is from the posterior. So this is why you see my probe, or this is why our beam is coming. It is coming from posterior and going anteriorly. And that is when you get this kind of shape of the prostate. You get the actual onion shape. Ladies and gentlemen, I have to apologize. My sound might not be good. It's raining out here. I might get some interference. Please, let's bear. So you get this kind of onion shape. So ideally, this is the posterior prostate, and then this dome is the anterior part of it in this coronal image of ours. And when we come to the sagittal, remember the sagittal is at an angle, depending on how you have pushed in your probe. This is anterior. Now towards my right corner, this is the anterior, and this is the posterior. You can see our seminal vesicle there. Now, this is our base of the prostate. We said the base is towards the urinary bladder. This is the urinary bladder. And then our apex is towards or is away from the urinary bladder. Now, it's optional, depending on how it helps you. You may have a partially filled bladder, or you may have an empty bladder, but we shall see the advantages. Now, already this is giving us part of the anatomy. This is a transitional zone. This is the peripheral zone. But I must say, in a normal individual, it is difficult to differentiate these zones by ultrasound. But when you have the 40, 45 plus individuals, you can clearly identify these zones. But if you're going to get 30-year-olds and below, it is difficult to divide this prostate into its different zones. But as for this, you can clearly see this, this is the peripheral zone. So the peripheral zone is predominantly posterior. And then the transitional zone is predominantly anterior. Ideally, it is the smallest, it is not supposed to be seen. But this we are able to see because it is enlarged. Again, we can see our peripheral zone is predominantly posterior here in our sagittal image. And then just anterior to it is the transitional zone. And the transitional zone sometimes crosses the urethra and is part of it is anterior. And then most anterior is the fibromuscular zone. Now, I must mention this right now. Most of the masses you may get in this fibromuscular zone, they will be mostly inflammatory and just do not, they rarely have malignancy in them. Now, that was transrectal. I believe most of us have done this. This is the transabdominal. This is our prostate. This is our distended urinary bladder. This is what we are doing, or this is what we have been doing. But like we have seen, there is not much you can get from this transabdominal. Really, you cannot split the prostate into its zones. With this transabdominal approach, it's not possible. If at all you are able to, it is in rare instances. So this calls for us to take a shift from doing the transabdominal to transrectal, especially if you are dealing with a patient who is into the category, the suspicious category, 40, 45 plus. Let's shift to that. Often, myself, I have initiated it myself. I no longer do transabdominal scans for the prostate in any person above the age of 40. Even for those who are below the age of 40, we have what we call the pelvic syndrome in males. Just like there is PID for the females, there is the pelvic syndrome, pelvic pain in males. You have prostatitis. It's going to give you pain. But when you do transabdominal, most times you will have a normal scan. But when you do transrectal, it is easy to pick out the signs. We shall see what prostatitis looks like. So this is the normal, or this is how your transabdominal images will appear. So what are the indications of doing a prostate ultrasound? Most often you will have an abnormal PSA if it is greater than 4 nanograms per milliliter. Then if you do a digital rectal exam, the first image I showed up, you just inserting your finger through the rectum and push it anteriorly. You can easily palpate the prostate and you can tell if it's enlarged or if there is a mass. And then if you are suspecting infections or abscesses, if you are evaluating for prostatic hypertrophy, especially in circumstances where you have urinary tract symptoms, if you want to aid in transrectal biopsies, now this is for the physicians, for the urologists, for the radiologists. If you have hematospermia, you are seeing blood in semen. We want to know what is happening. We have seen the prostate plays part in semen content. Then if you have hematuria, there are so many causes of hematuria. Presence of blood in urine. It may not entirely be out of the urinary bladder. It could be urethra, it could be from the prostate, it could be from the vasa deferens. So this is also part of the indications and many more that we may not have listed here. So when you are doing a prostate ultrasound, especially transrectal, what are the key observations you have to make? First and foremost, we are interested in the shape. I'm saying here, the shape of the prostate is predominantly onion shaped. We all have seen the onion. If you get your onion and put it on the table, it is ovoid, right? It is ovoid with a base and an apex. So when you are looking at the shape, we are looking for asymmetry. If you look at the left and the right, or if you look at the posterior and the anterior aspects, are they symmetrical? Shape, predominant onion or ovoid. Look for asymmetry. Next, we are looking at the size. You have to take a measurement. We are going to see how this measurement is taken. And the normal volume for prostate, we take the volume. And the volume is normally between 20 to 30 centimeters. That is for PSA less than 4 nanograms per milliliters. Please take note of this PSA. Most of the volume will be between 20 to 30. And then we look at the ecotexture, the ecogenicity, and how smooth the parenchyma is. It is predominantly homogeneous and smooth. And then we look at the capsule. The capsule is very important to look at. We are going to see in circumstances of malignancy, the capsule is tampered with. And once it is tampered with, it has a significance, or it is trying to tell you something. And then last but not least, we have to look at the color flow within the prostate or the prostatic parenchyma. So let's start with transrectal. Again, this is my onion. Oh, this is our onion. This is our prostate. And like you can see, it is difficult for us here to tell the zones of this prostate. This is because this looks normal. Like I said, in a normal prostate, it is difficult to split up those zones unless you are doing pathology, histopathology. But this is our onion shape. And this is the sagittal image. This is how it looks like with our base here and our apex here. And this is the main gland. Then you look at the capsule. Look at the capsule. It is indeed small. Very important. Very important. Then if you are keen enough and you look outside the capsule, we look at the neurovascular bundle. That is the nerves that supply the prostate and part of the urinary bladder, and then the vasculature. It is usually just outside the capsule. Are you right? So onion shape or ovoid, smooth capsule, homogeneous echo texture or echo pattern, and difficult to tell of the zones. And then when we are measuring the size, please take note, this is how we measure, this is how we take our measurements. This is the longitudinal measurement, and this is how we take the other parameters. And the volume, like we said, normally it's been, excuse me, normally it's between 20 to 30. Now, the images here is further to demonstrate more of the anatomy. We are able to tell the transitional zone and then the peripheral zone, this one here. For those of you who have cows, the peripheral zone usually mimics cattle horns. From here, if you swing from the left to the right, it mimics the cattle horns or the buffalo horns. At least we all have seen the horns of a buffalo. Now, when you have a partially filled bladder here, you're able to see the urethra and how the urine is getting into the urethra. That is part of our transitional zone. And you can see the peripheral zone down there. And then look at the capsule. Look at the capsule, very smooth. Even here, you look at the capsule, it's smooth all throughout. That is, particularly this is the normal appearance. The first two images here, that is the normal appearance. This is for transrectal. Very clear and very nice images because we are close to the area of interest. Just like in transvaginal, you can easily pick very nice and clear images. Now, when we go to transabdominal, you have already seen this image. You can see, that is our urethra there, the V sign, and this is our prostate. But this is our actual image, but you really can't appreciate enough of it. Right? Even when you look at the capsule, you can't really define it. And the pubis is obscuring you from obtaining the actual contour of the capsule anteriorly. This is why we are discouraging the transabdominal. And when you are taking your parameters, again, this is how you take your parameters. Now here, many of us have been doing a mistake, or we are still doing a mistake. We tend to take this longitudinal measurement, and then we attempt to do another parameter perpendicular to this. But we can't define this anterior capsule. Please don't attempt to extrapolate to what you cannot see. We can't see the capsule here. So this is the preferred method of doing it. At least here we're able to see the capsule, part of it. So take this one parameter, which is the longitudinal, and then do the other parameters from the actual image. If you permit me to go back to these images, surely we can appreciate more on transrectal, and you can get better images than transabdominal. So today, from now and onwards, let's shift to transrectal. Unless you have a contraindication. For example, you may have a rectal malignancy that it does not enable you to get the prostate transrectally. If your machine is unable to give you the volume at once, and it matters, this is you just multiply these measurements, because it will give you as a distance measurements. You just multiply them, and then what you get, you multiply it by this figure. Now, particularly for this one, this is what it is able to give. Here I'm only demonstrating if your machine is unable to give you volume at once. That is for this transabdominal, sorry. What are the common pathologies we get to see for the prostate? The first one is prostatitis. And this one is divided into two. Sometimes it could be inflammatory, or it may not be inflammatory. Now, we are used to this word, tis meaning inflammation. But sometimes you're going to get signs of inflammation. But when you take this specimen to the laboratory, there is actually no signs of inflammation. But the features you are getting on ultrasound is showing you signs of inflammation. So this is why we are saying it could be inflammatory or non-inflammatory. But this is not for us to take. It is difficult to discern this. This is left for the pathologists. So in prostatitis, what are we looking for? We are going to lose the ovoid or the onion shape of the prostate. So you have a more rounded prostate. Then you have reduced echogenicity because of edema. And then it is difficult to discern the zones because of browning. Sometimes it is heterogeneous and with hypoechoic areas. Then the halo sign in the periurethral zones. You will get calcifications, especially in the apical zones. And sometimes you get fibrosis. Now, in inflammation, just like inflammation elsewhere, you get increased vascular flow at color Doppler. Then we start with this. You have this pair, you have a prostate here. You can partially tell the zones, but we have a few areas, some hypoechoic, some hypoechoic, and then this is the urethra. Then you have the halo side of the periurethral areas, just like here. And even sometimes the halo side extends towards the capsule. And then here you have calcifications, and you can see this prostate is heterogeneous. Just look at this, it is heterogeneous, and sometimes is mimicking small masses within it. Typical. In prostatitis, you have prostatic abscesses. You can have this appearance. Now, most often, very many people mistaken abscesses for malignancy. But we know what abscesses are. I don't want to dwell so much on them. But we have different appearances here of abscesses. The clinical perspective of abscesses, you will mostly get fevers. So consider your clinical presentation of the patient too. We have another appearance here. Maybe something I have to mention here. You can see I have inverted my images now. Image orientation is individual based. Orient your image to the easiest way you can interpret them. You can have this and you provide your pathology there. And you know this is the posterior part of it. You see the urinary bladder there. Or you can have this. Okay? This is now the posterior part. And this is the bladder, meaning this is the anterior part of it. Image orientation. But what we are interested in is show us the pathology and clearly describe the pathology and where it is located. Like you can see, this is, this is located in the peripheral zone, which is predominantly posterior. Some of the abscesses previously, you know, technology is advancing. At the start, MRI would not, or if you do pelvic CT scan and you're unable to discern, is this a solid mass? Are these two the same because they have the same density? They have the same density, so you may not discern this. Even at times when CT applies the house field units and it gives you close to the same value. But nowadays, the new MRIs are advanced. They can clearly differentiate a cyst from a solid mass. But this is where then ultrasound was used. This is a cystic mass and this is a solid mass. Here, this is the cyst, but you can't tell, but ultrasound will show you this cyst. This is a solid mass, and ultrasound they can clearly delineate this is a solid mass. But the new modern machines are able to do it. Now, the commonest pathology, or the commonest indication is benign prostatic hyperplasia. Some call it hyperplasia, some call it hypertrophy. But it is predominantly hypertrophy. Now, what are the symptoms? You have bladder outlet obstruction. Usually you have a volume that is greater than 10 to 20 cubic centimeters. And this person has urine frequency. At night, this person is in and out of the bed to go and void. Then someone tells you they have a weak stream or they are straining during micturition. They have hesitancy, intermittence, urinating every after maybe 10 minutes. And then incomplete emptying. Or when you have the PSA a bit raised, or sometimes it could be normal. So these are the symptoms. When you have this, you are thinking of BPH, and what do we look for in BPH? First and foremost, you may have a generally enlarged gland. The entire prostate is enlarged. The volume is greater than 30 cubic centimeters. And you may have to see multiple hypoechoic or isoechoic or hypoechogenic lesions within its parenchyma, just like we have seen a few images above. Or because it is enlarged, the peripheral zone and the central zones, they are compressed by the transitional zone. So the peripheral and central zones become hypoechogenic. Now, what am I trying to mean? At the start, I said the transitional zone is the zone that is responsible for this BPH. It is the predominant area that produces this BPH. I hope this is clear. So, because it is predominant anterior, it compresses the zones posterior to it, and they become hyperechogenic. But there is something very funny, and I want you to listen to this carefully. You may have a normal volume of the prostate gland. It is less than 30 cubic centimeters. But the moment you see an enlarged transitional zone or the median lobe, that automatically qualifies that to BPH. I repeat, if you have a normal volume of the entire prostate, but the transitional zone is enlarged or the median lobe is enlarged, it qualifies it to be a BPH. I hope this point is clear. Now, this is common. You're going to get this between people who are 35 to around 40, 45. You have those towards that margin. So you have a normal volume of the prostate, but the transitional zone is enlarged. That automatically qualifies it to a BPH because the transitional zone is the one responsible for this enlargement. But predominantly we'll have the capsule very smooth. In BPH, our capsule is predominantly smooth. So if you do a transabdominal, most of it, this is what you're going to see. This is our transabdominal approach. This is what we have been getting or what we are getting. I say, do we normally make this mistake when we are measuring? Let's avoid it because sometimes you can't clearly define this capsule. Now, something important here that the urologist is interested in, we have this portion that appears to be protruding into the urinary bladder, this portion. Now, part of the management for BPH, they can partially remove majorly this median lobe and the transitional lobe. There's what they call transurethral partial prostatectomy. Before the urologist goes in to remove this portion, they normally ask what is the size of this that is protruding into the urinary bladder. Even when they have not asked for it, please take this measurement. Just this portion that protrudes into the urinary bladder. Please take its measurement. In the sagittal, we want to know the length because it guides the urologist or the surgeon how much should they resect or remove out. So this is our normal appearance in BPH. Excuse me. We have smooth walls, but you can see the gland is indeed enlarged. But we cannot tell much from this transabdominal. But when we go to transrectal, you can see here we are able to design the zones. And this is the transitional zone. It is enlarged, just like here. Transitional zone, the moment you see it and you can define it from the other zones, then it is enlarged because it is the smallest. But once you start to identify it, then we have BPH there. But in some circumstances, you have uniform enlargement that it does not delineate for you the zones, just like here. This is uniform enlargement. It is not defining for you the transitional or the peripheral zones. So pathology is not static. Pathology is not in the books, but it is how we receive our patients, how we correlate their presence and their perspective. So do not take it for granted that always you are going to see the transitional zone. That is the predominant feature. But you'll have instances where you have uniform enlargement without distinction of the zones. And by truth, this is how it appears. And you can see our capsule. And we have a more rounded prostate. We have a more rounded prostate than ovoid. Okay. Next is the notorious CA prostate. Those of us who are going towards that age, let's enable our juniors and equip them with knowledge and this skill. because at a certain time we'll need to undergo this screening. So the CA prostate and the metastatic pathways. I'm putting the word metastatic pathways. The imaging technologists or the radiographers, sometimes you are doing a lumbar spine X-ray, or you are doing an MRI or a CT scan, and you suspect metastasis, or you see metastasis in the spine. But this patient has never had a pelvic ultrasound. So what you do, you immediately send for screening for CA prostate. Now, what are we looking for in the CA prostate? Usually in CA prostate, the PSA is greater than 10 nanograms per milliliters. And as per research, 50% of these cases with PSA greater than 10, they are positive for malignancy. Now, at ultrasound, you have a hypoechoic lesion, usually in the peripheral zone. We said at the start, the peripheral zone accounts for 70% of the malignancies. So once you find a hypoechoic lesion with poor margins, ill-defined in the peripheral zone, the higher chances that this is a malignant lesion, the percent is high. Now we have this measurement, what we call the PSA density. This PSA density gives is 80% sensitive to CA prostate. And it gives confidence to avoiding biopsies. But I want to emphasize, much as it has high sensitivity and it gives this confidence to avoid biopsies, always remember we have true negatives and we have true positives. So do not take it for granted that once your PSA density is above the normal value, you are dealing with malignancy. But 80%, you are dealing with CA prostate. Now, what is the PSA density? You take the value of the PSA. This is done in the laboratory. Take the value of the PSA. You divide it by the volume of the prostate. But that volume only and specifically must be by transrectal ultrasound. So the value of the PSA divided by the volume of the prostate strictly by truth. And the normal value you get is between 0.12 to 0.15. If you have a value greater than this, then there are higher chances that you are dealing with malignancy. But that is when you have seen a hypoechoic lesion and with irregular margins, irregular capsule of the prostate, and it is predominantly in the peripheral zone. And then your PSA density is above this value. How do we get metastasis? Now, when the patient has CA and they have metastasis to the spine, it is predominantly through the posterior vertebral arteries. Some of the prostate, the drainage of the prostate drains into the posterior vertebral veins. That is why we get metastasis in the spine. So if you are doing a lumbar sacral X-ray, a pelvic X-ray, or you are doing MRI or CT and see metastasis, this is the metastatic pathway, the posterior vertebral veins. Immediately that should alert you, go screen this patient for CA prostate. That is if you have ruled out any other causes of cancer, because metastasis can go anywhere, from the liver, it can be colon, it can be from the stomach. And then we have direct invasion. Direct, you have the prostate. This is why we are emphasizing, look at the capsule of the prostate. If you find it irregular and you have a lesion with irregular margins, then this cancer or this malignancy is beginning to invade other areas. it is going through the capsule, and usually it eats off either the posterior urinary bladder wall, or it even exceeds and goes to the rectum. And then, excuse me, the other pathway is through the lymphatics. These are the commonest. Direct hematogenic or lymphatic. I want us to look at this question, and this is a take home for many of us. This is what we are going to do. We are going to do transrectal prostate ultrasound. For research, many of the patients with CA prostate between the age of 40 and 50, the cancer is extremely aggressive, and the death rates are higher between this age group. Why is it so? Let's go. This is my take-home question. Why is cancer of the prostate aggressive in this age group? Me and you, let's find out in our daily practice. So transabdominally, at most, this is what you're going to get. You have multiple nodules or multiple lesions, hypoechoic. You can't clearly define the margins. And when you look at the capsule, at least you can't, it is not smooth. You have lesions, but you can't tell the margins. This is what you will get transabdominally, but this is rare. Now, why I say this is rare, in this image here, you can see the lesions are very many, but why we are discouraging transabdominal, you will get a normal prostate with a lesion as big as only 3 to 4 millimeters. These lesions are more than 3 to 4 millimeters, but even a lesion of 2 millimeters is having malignancy and is something to worry about. You don't pay attention to it, sooner than later, you are paying for the consequences. So transabdominal cannot show you lesions less than 4 millimeters or less than 3. That is why we are discouraging transabdominal. Again, when you look at this image here, this lesion is going past the capsule of the prostate. This is the invasion of the adjacent tissues. So once you have this appearance, then suddenly you are dealing with CA prostate or you are dealing with malignancy. Let me sound a warning here. When you get such features, are you going to say in your report, features are of CA prostate? Usually, I say, I'm not a pathologist. We are imaging technologists, sonographers, radiologists. It is only maybe the physician who is managing this patient or the pathologist who can confidently say, this is CA prostate. Many at times, the physicians or the radiologists want to do a biopsy. Even when we have shown confidently that high chances we are dealing with malignancy. But on our side, let's not be pathologists. Let's be experts in imaging. We are the eyes of medicine. Because we see this, it is not the pathologist will go to take a biopsy before there is an alert. For us, let's be alert of an impending danger. Do not put your 2 feet to stamp that this is CA prostate. You can only suggest and alert. So this is the transabdominal appearance. Now, when it comes to transrectal, surely we can see the different variations. You have multiple, these small lesions, hypoechoic, with ill-defined margins. This is a lesion, ill-defined margins. And when you look at this lesion, our capsule contour is obliterated. You have another lesion here. And by image orientation, these lesions are in the peripheral zone. And we said once you have lesions in the peripheral zone, ill-defined irregular margins obliterating the capsule, there are higher chances, 70 to 80% that you're dealing with malignancy. The same appearance here. You can see some of these lesions are too minute to be seen on transabdominal. Look at this lesion here. It is too posterior that if you did the transabdominal, by the time you pick this lesion, it is surely more than 4 millimeters. There's another lesion here, and it is obliterating our capsule here. Now, again, if you're going to do a biopsy, it is difficult for you to discern. You can see this is a peripheral zone. We said it is difficult for you to tell the zones. But when you're going to do a biopsy, especially for the radiologist or for the physician, now the physician, if the physician is going to come, or the urologist is going to work with you, the sonographer or the imaging technologist, tell him or her the approach is translational. Because even, like we have said, most of the lesions are in the peripheral zone, it is easier. Just imagine from the probe here, immediately you go to the lesion. Other than using the anterior approach, you're going to have to go through the bladder, the anterior abdominal wall. You're going to go through some of these other zones. There is more tissues traumatized than when you go transrectal. So, ladies and gentlemen, I'm emphasizing the appearance of these lesions transrectally. It is very easy to pick even the smallest and the tiny lesion by transrectal compared to transabdominal. Let's change our approach. The area we detect these small lesions, the area we are going to prevent the prevalences and the costs of managing these cancers. As we exit from the prostate, we have accessory organs. We have the seminal vesicles. We can't avoid these because they are part of the system. And very many have described them as a mustache. The men who have beards know what a mustache is. The ladies, the mustache is to the beards, to the upper lip, just below the nose, and only restricted to that area, while the rest below the lips and the rest of the cheeks is devoid of the beards. So this is the normal appearance, and it is posterior to the bladder, I mean to the prostate, superior. And this is the normal appearance, transrectally. And the good thing with transrectal, we are able to see the vasa deferens, how they come into the seminal vesicles. This is the beauty of transrectal. This is the same image demonstrating the seminal vesicles and our vasa deferens as they come to go into the seminal vesicles. I have to mention about this infertility. I did not mention it among the indications for prostate ultrasound. This was deliberate. The percentages of the request forms we receive, and you have a request seeking for infertility, male infertility, it is very minimal. Personally, I think it is like 1/500. For every, I don't know, that's too much. Let's say for every 100 patients, you'll maybe get one where they are requesting do prostate ultrasound, because they are querying it could have an effect on infertility. Now, in male infertility, we have pre-testicular factors. These are genes. Some of the genes are deleted off the DNA. We have the testicular factors, that is disorders in spermatogenesis. You have trauma, or you have unsated testes or varicoceles. These affect sperm production. And then we have the post-testicular factors. Now, this is where ultrasound of the prostate comes in. When you have azoospermia, you have almost no sperms in the semen. What is happening? You have very few sperms. What is happening? Now, how prostate ultrasound, or the role of prostate ultrasound in this is, you have obstruction of the urethra, and we can only do it by doing the prostate, depending on the level where this obstruction is. Predominantly, it is in the prostate. Or you could have urethral strictures. Those ones we are unable to tell by doing prostate ultrasound. But we can see some caniculae in the seminal vesicles, like you see here, or in the vas deferens. For example, if I come back here and you find calcifications obstructing the vas deferens. So when they do laboratory analysis, the semen has no sperms, but you do a transrectal ultrasound, and you're able to show why actually there is no sperms, there is obstruction of the vas deferens. Or in the ejaculatory duct, there are calcifications, and these are very common. Or in the prostatic urethra. So obstruction of the ejaculatory duct or the vas deferens. You can only get this at the level of the prostate. Now, as we wind up, some of these techniques are being overtaken by invents. As per now, MRI has higher sensitivity and specificity to detecting CA prostate than ultrasound. But we know the cost of MRI. In some of our countries, we have not more than 1 or 2 machines, yet we have higher numbers of patients. So we can't get, all our patients can't afford or can't reach some of these technologies. But we have some other ways we can detect some of these cancers. Elastography is one of them. And the elastography has two ways. There's compression elastography. This one, basically, it's about compressing tissue and detecting its elasticity. How compressible is this tissue? In cancer of the prostate, or most of the cancers, the tissue is hard. It is not really elastic. So when you compress tissue and it is not that compressible, then the higher chances is that you are dealing with malignancy. Now, this is complementary to all the other factors we have talked about in the previous slides. Then shear wave elastography is about detecting the velocity of sound, how fast does sound travel in this tissue. I'm going to give 2 examples. The velocity at which ultrasound travels in a metal is not the same velocity in wood or in plastic. We expect sound to travel higher, at a higher velocity in metal. Now that is to matter compared to plastic. So in CA, you have, once you start to get, if you are using shear wave elastography, and you see the velocity of travel of sound in this tissue is higher, then suddenly this tissue is not normal tissue. It is becoming rigid. It is not elastic. It is becoming something more solid. That is elastography. You can also do MRI. MRI also has elastography. And then we have contrast enhanced. Unfortunately, I personally haven't done this. I won't talk about much of it. We haven't gotten clearance from a national drugs authority to import or use contrast material in ultrasound. And then the last of the techniques is MRI. It is so far the best, and it is the best for staging. If you have done your ultrasound, you have followed all your protocol, you have scored most of the features we have talked about, and maybe the biopsy has been done, or you have confirmed this is CA prostate. MRI is the best for staging. It has what we call the PIRADS, the Prostatic Imaging Reporting and Data Systems. Just like we have done for BIRADS breast, for thyroids in thyroids, LIRADS for the liver, or OVIRADS for the ovary. So MRI has better staging because of these PIRADS. And MRI we know has good tissue delineation. But I must say, new technologies or new machines are coming that have an equally good sensitivity to discerning soft tissue densities. But as of now, if your patient is able, or if you're able to access MRI, you can do your staging there. This is just an emphasis to elastography. This is our normal prostate. This is smooth, and this is how we do our, just like we do for color Doppler. Many of the machines have a preset for elastography. You put your cursor for elastography, and this is the normal appearance. And then when you have lesions here, you see your capsule is obliterated, your prostate is enlarged with so many lesions, and when you put your elastography cursor, it is giving you different, I would say, color densities. When you of elastography, this is when you look at the abdomen. And sometimes we have had chances of elastography totally eliminating biopsies. Now imagine you combine, you have a peripheral located hypoechoic lesion with irregular margins. You have your PSA density above the value we talked about. You do your elastography, and it is giving you features of malignancy. Surely, it gives a good percentage of eliminating a biopsy. We know a biopsy is at times invasive, and some of the disadvantages of a biopsy, you may pick normal tissue and leave the diseased tissue. Histopathology is done, the results come back, they are showing no features of malignancy. But when in actual sense, what was biopsied was normal tissue, you missed biopsying the lesion. So this is how ultrasound plays in hand with elastography, and how partially it can eliminate biopsies. These are some of the references you can check out with. My take home is, let's change to transrectal approach for screening, for detecting, for monitoring, and for discerning how much of the prostate is affected, or what pathologies are we dealing with. Those of us who are males, every day we are celebrating birthdays, but we are towards the dangers of CA, especially if you have a family history, either brother, your father, or your grandfather having had CA prostate, your chances are increased. Let's teach, let's take on these new trends, let's practice them, let's put them to research. Go and do a study. For every scans you are doing, how much lesions do you get? How many of them are turning out to be cancers? How many of them are turning out to be benign? I thank you, dear ladies and gentlemen. I thank you, Chiza, for contacting me and the entire team for Radiology Without Borders. I'm sorry if I have taken more time than usual, but thank you very much. I await for questions. Let me hand back to Chiza to take on.
Thank you, Mr. Vitus.
Oh, yes.
Thanks a lot for the presentation. It was a great presentation. Actually, it was well packaged and well delivered. Like we usually say, medicine upgrade our machines and our knowledge. Because from this presentation, I can say very many conditions go unnoticed from what I've realized here. Maybe if I can, before I call in others, allow me to first ask like 2 questions. The first one, I want to ask about volume. How reliable is the PSA density when you use transabdominal measurement? Then the other question would be calcification, because from literature there is under normal variation. They usually mention calcification as one of the variations, the normal ones, but also in chronic prostatitis is also measured. So is it a matter of the location where it's located? When do you decide this is normal variation or this is related to any condition?